Good morning, everybody. You see, in anatomy, we have 9 topics to cover. The 2 extremities, thorax, abdomen, pelvis and perineum. Head and neck, neuroanatomy, not audible. Head and neck, neuroanatomy. Then the developmental anatomy, osteology and histology. These are the 9 topics that we are going to discuss in our classes. You see, most of the questions that are going to be projected in our classes are very much condensed, so as to include most of the relevant things, relevant chapters in that topic. Each question can be expanded into 5 to 10 because it's very much condensed. First, the question will be projected. I have to find out the right response for that question. After that, the diagram, illustration will be projected. Explanation will be given. Again, the same question will be projected. You should be in a position to choose the right answer after that. Today, we are going to discuss 2 topics, upper limb and lower limb. First, we shall start with questions from upper limb. Read the first question and try to find out the right response for this question. I think I am obstructing the view. Let it be like this. The present day classification of axillary lymph nodes is based on their relation to one muscle. Which is that muscle is the question. Which muscle you want to choose? You just show your digits. 1 for A, 2 for B, 3 for C and 4 for D. You want to choose number 3. That is pectoralis minor. Perfectly correct. Look at this muscle. This is the muscle, pectoralis minor, taking origin from 3rd, 4th and 5th costal cartilages and is inserted into the coracoid process. You are seeing several lymph nodes. They are the axillary lymph nodes seen around this muscle. This is how they are classified. First we see some lymph nodes below the muscle here. They are the level 1 group, lower group. Then we see lymph nodes behind the muscle, level 2. Also we see lymph nodes above the muscle, level 3, upper group. So we have 3 groups of axillary lymph nodes, lower group, middle group and upper group. In addition, you also see some lymph nodes on the surface of the pectoralis minor, superficial to the pectoralis minor, or in other words, between the pectoralis major and minor. Therefore, these nodes are called interpectoral nodes, also known as Rota's nodes. How the lymph from the breast is drained? We know more than 75% of lymph from the breast is drained into the axillary lymph nodes. More than 75% of lymph from the breast is drained into the axillary lymph nodes. The lymph is first received by the level 1 group. Level 1 group, lower group. From there the lymph reaches the level 2. From there the lymph reaches the level 3. That is upper group. That is how the lymph from the breast is drained. Afterwards to the right lymphatic duct or the thoracic duct, where the lymph meets the bloodstream in our body. So this is how the drainage. Majority of the lymph drains from nodes at level 1 sequentially to those at levels 2 and 3. Also a small amount drains to the interpectoral nodes. So this muscle forms a relation to these lymph nodes. Do you know an artery which is divided by this muscle into 3 parts? Which artery is it? Subclavian artery? Axillary artery. Subclavian artery is in the neck, root of the neck. Axillary artery we see here. But the subclavian artery also is divided into 3 parts by another muscle. Which is that muscle? Scalenus anterior. So scalenus anterior divides the subclavian artery into 3 parts. Pectoralis minor divides the axillary artery into 3 parts. Further, the lymph nodes, axillary lymph nodes are seen around this muscle. Is this the only muscle attached to the coracoid process? Two more muscles are attached to the coracoid process. They take origin. They are the shorter of the biceps and coracobrachialis. What type of epiphysis does the coracoid process represent? See, epiphysis, growing bone, are divided into four types. What are the four types of epiphysis that we know? The site of ossification, that is epiphysis. Pressure epiphysis is one type, pressure. If ossifying centers develop due to pressure applied to the bone, that type of epiphysis is called pressure epiphysis. For example, you see the lower end of the femur, upper end of the tibia, two condyles are formed, because of weight transmission. The body, our body is supported by these two bones around the knee joint. So, those areas undergo proliferation, that area, and projections develop in the bone due to pressure applied to the bone. This type of epiphysis is called pressure epiphysis. So, typical examples, condyles of the tibia and femur. Traction epiphysis is the second type. We see several projections in many long bones, like greater tubercle, lesser tubercle, greater trochanter, lesser trochanter. These are all projections on the surface of the bone. How do they develop? You see, all these projections give attachment to the muscles. When the muscles act, these parts of the bone are pulled by the contraction of the muscle. So, projections appear, elevations appear on the bone. Such a type of epiphysis is known as traction epiphysis. Due to traction applied to the bone, epiphysis develops. So, all tubercles, ridges are examples of traction epiphysis. Atavistic epiphysis is a peculiar epiphysis. Actually, you see the coracoid process, typical example, it is actually an independent bone in lower animals. In birds, it is an independent bone, it is not a part of scapula. It was an independent bone in human being also in the beginning, phylogenetically. Later, the coracoid process gradually approached the scapula and fused with the scapula and became a part of scapula. That's what happened. So if an epiphysis develops by fusion of another bone with a flat bone or any other bone, that type of epiphysis is known as atavistic epiphysis. Atavistic epiphysis. There are some epiphyses which do not come under any of these types in our body. This type of epiphysis is then called aberrant epiphysis. Aberrant. Example, head of the first metacarpal bone and basis of all other metacarpal bones. So this way, four types of epiphysis have been described. So questions can be said. Which of the following bones represent the atavistic epiphysis? A question can be said like this. Coracoid process is an example of what type of epiphysis? 1, 2, 3, 4 given. Or condyles of femur, what type of epiphysis do they represent? If questions like this are asked, then you can answer these questions without any difficulty. Okay, we shall go back to the question now. For this one, what you have chosen is perfectly correct. Pectoralis minor is the right answer for this question. Also, we have understood the two arteries divided by the pectoralis minor one and the other is calenus anterior. Here there is a stab wound in the neck. It has damaged one of these nerves. What is the difficulty? What is the problem the person faces? He is not able to abduct his arm above his shoulder. This is what is called overhead abduction. He is not able to lift the arm above the head like this, following injury to this nerve. Injury to which nerve do you suspect and why? Number please. Number 2 you want to choose. Number 2 means accessory. Anything else? Long thoracic nerve. Okay. It's not there. It's not given. See, to answer this question we must know the muscles which produce abduction at the shoulder. Abduction at the shoulder can be described at 3 levels. One is the initiation of abduction, that is first 35-degree deviation from the side of the trunk. Up to 35 degrees from the side of the trunk. This is called initiation of abduction. This movement is carried out by one muscle. You know that muscle? Supraspinatus. Supraspinatus is the muscle responsible for initiating abduction. You know the nerve supply of this muscle? Suprascapular nerve. Both the supraspinatus and infraspinatus are supplied by suprascapular nerve. Supraspinatus, infraspinatus are the muscles of rotator cuff. Supraspinatus is the muscle of rotator cuff. Musculotendinous cuff of shoulder joint. So, but the person is not having any difficulty with the initiating abduction. Therefore, supraspinatus is not paralyzed. In other words, the suprascapular nerve is not injured. So, you can eliminate the suprascapular nerve first. Now, the next abduction is up to 90 degree. Taking the arm to a horizontal level, up to 90 degree. This is the horizontal abduction, up to 90 degree abduction. This is carried out by one muscle, deltoid. Yes, deltoid muscle is responsible for abduction up to a horizontal level. You know the nerve supply of the deltoid? Axillary nerve. Axillary nerve is the nerve that supplies 2 muscles in our body. One is the deltoid, the other muscle is teres minor. So if the deltoid is paralyzed or axillary nerve is injured, the person will have difficulty with abduction up to 90 degree only. But the person is having difficulty with overhead abduction. So you can eliminate the axillary nerve. Further, axillary nerve is not found in the root neck. It is found in the axilla. So you can eliminate the axillary nerve. Overhead abduction is carried out by 2 muscles. 2 muscles are responsible for taking the arm above the head. They are the trapezius and serratus anterior. 2 muscles are responsible for this. Strictly speaking, this movement does not occur at the shoulder joint. Abduction up to 90 degree only is possible at the shoulder joint. Then what is this due to? This is because of the rotation of the entire shoulder girdle upwards. The scapula moves laterally, rotates laterally, taking the arm above the head like this. This is not a movement occurring at the shoulder joint. It is due to upward or lateral rotation of scapula. So there are 2 muscles moving the scapula laterally rotating the scapula. That is, what is lateral rotation? The inferior angle of the scapula that we see here on either side of the vertebral column moves laterally away from the midline. The inferior angle moves laterally. When you do like this, naturally the inferior angle of the scapula moves laterally from the midline, vertebral column. We know the nerve supply serratus anterior. Which is the nerve that supplies the serratus anterior? Long thoracic nerve. Yes. If the long thoracic nerve is injured, the person will have difficulty with overhead abduction. But that nerve is not given here. Further, the long thoracic nerve begins from the root of the neck. It is not seen in the middle of the neck. It starts from the root of the neck. And it is placed very superficially on the side of the thorax, on the lateral wall of the thorax. Therefore, it is unlikely to be damaged. by a stab injury in the middle of neck, sideways. The other muscle, trapezius, we know the nerve supply. Which is that nerve? Yes, spinal accessory nerve. Spinal accessory nerve descends very superficially in the neck like this. Look at this nerve. This is the spinal accessory nerve. The 11th cranial nerve is called accessory nerve. It comes out of the cranial cavity through the jugular foramen along with the 9th and 10th cranial nerves. So 3 cranial nerves come out through one foramen. 9th, 10th and 11th cranial nerve. That foramen is called jugular foramen. Why is it called jugular foramen? Because it transmits the internal jugular vein also. So internal jugular vein also you can see, internal jugular vein, this accessory nerve, glossopharyngeal, vagus, you can see the vagus here. All these things come out through a single foramen, internal jugular vein and 3 cranial nerves. And the accessory nerve soon separates into cranial part and spinal part. The cranial part does not have an independent existence in our body. What it does, it immediately joins the vagus and is distributed along with the branches of the vagus. But spinal accessory nerve descends very superficially in the posterior triangle of neck, as you see here. It descends like this and disappears from the site by going deep to the trapezius muscle. This muscle is the sternocleidomastoid. It gives a branch to sternocleidomastoid here, then it goes down and disappears deep to the trapezius, about 5 centimeter above the clavicle. This is the clavicle, 5 centimeter above the clavicle, it disappears by passing deep to it. So in this part of the neck, the nerve lies very superficially, therefore can be easily damaged. For example, you want to drain an abscess from the neck, cervical lymph node abscess or anything. Careless incision made in this region can damage the spinal accessory nerve. If you are not aware of presence of such a nerve running superficially on the side of the neck, this nerve is likely to be damaged. If this nerve is damaged, 2 muscles will be paralyzed. One is the sternocleidomastoid, the other is trapezius. What is the action of the trapezius? The trapezius muscle has 3 parts, upper part, middle part and lower part. Then upper and lower part contract simultaneously, the arm is moved upwards like this. Overhead abduction is produced. So this muscle also is responsible for overhead abduction. And if this nerve is injured, overhead abduction becomes difficult. So we have seen 2 muscles responsible for overhead abduction. Suppose long thoracic nerve also is given as one of the choices. Will we choose the long thoracic nerve? No, because the wound is injury is in the middle of the neck, but long thoracic nerve begins from the side of begins from the root of the neck, as you see here. These are the 8 digitations of serratus anterior muscle. This muscle taking origin from the ribs, upper 8 ribs, and is inserted into the medial border of the scapula. And the nerve runs very superficially on the side of the thorax. This nerve is also called a nerve of Bell. So a penetrating injury on the side wall of the thorax can damage this nerve. Or when we do mastectomy, for example radical mastectomy, this nerve is in danger of being injured. If this nerve is injured, in addition to difficulty with overhead abduction, the person will have one more problem. What is that? See, this is not that this difficulty with protraction. See, this muscle is called Boxer's muscle. That is this serratus anterior. Why? This is the muscle responsible for protraction of the scapula, used by boxers for punching movement. How it is inserted into the medial border of the scapula, that is why it is able to move the scapula forward for this punching purpose. And this is the muscle that keeps the scapula against the thoracic wall. If this muscle is paralyzed, the scapula is no longer kept against the thoracic wall, therefore it protrudes out, it bulges out. That is what is called the winged scapula or winging of scapula. So in addition to difficulty with overhead abduction, the person will develop wing of scapula also after some time. And there will be difficulty with the protraction of the scapula if the long thoracic nerve is damaged. Anyway, this nerve is not given as a choice, therefore the right response for this question is spinal accessory. Yes, read this question. We know the axillary artery is the only source of blood supply to the entire upper limb. This is the parent artery of the entire upper limb. This artery is compressed by a tumor of the coracoid process. In spite of this compression, the radial pulse is normal. What does it suggest? The blood supply to the upper limb is not cut off. In spite of total compression of the second axillary artery, the blood flow to the upper limb is not cut off. That is why the radial pulse is normal. But we know this is the only artery supplying the entire upper limb. So this explains some collateral circulation. The establishment of some collateral circulation. A bypass route has been established following occlusion of, compression of the axillary artery. You might have studied an anastomosis on the back of the scapula, scapular anastomosis. This anastomosis is responsible for maintenance of collateral circulation following occlusion of axillary artery. We must know the arteries taking part in this anastomosis to find out the right answer for this question. What is this anastomosis? Which major arteries are linked by this anastomosis? Can you find out the right answer for this question now? We will see the diagram later. Number 4. Suprascapular and subscapular arteries you want to choose. Anything else? I will increase the size of the pointer. Mouse-ന്റെ ഡീറ്റെയിൽസ് അവിടെ പോരാ, അവിടെ കിട്ടുന്നില്ല. പോയിന്റിംഗ് ഡിവൈസ് വേണം. ഇല്ലെങ്കിൽ ദൂരമുള്ളവർക്ക് ഈ മൗസ് കാണാൻ കഴിയില്ല. അതാണ് നോക്കുന്നത്. മൗസ് വരുന്നത് കൺട്രോൾ പണില്ലാണ് വേണ്ടത്. മൗസ് ഇവിടെ ഉണ്ട്. അതിന് ഇവിടെ ഉണ്ട്. ഇല്ല ഇല്ല ഇതല്ല, ഒന്നും വരുന്നില്ല. അവിടെ വരുമ്പോൾ ഇത് വരുന്നുണ്ട്. ഇങ്ങനെ പോരാ. പോയിന്റർ ഡിവൈസൊക്കെ ഉണ്ട്. മൗസ് സെറ്റിംഗ്സ് നോക്കട്ടെ. പോയിന്റിംഗ് ഡിവൈസ് എന്നെ വിട്ട് കണക്ട് വന്നു. ഇതാണ് വേണ്ടത്. this. So we shall see that anastomosis on the back of the scapula. This is the first part of the subclavian artery. The subclavian artery, as we have seen before, is divided into three parts by the scalenus anterior muscle. And this artery is continuous with the axillary artery from the outer border of the first rib. That is the extent of the subclavian artery. From the outer border of the first rib, we call that artery axillary artery. You can see the subclavian artery is continuing as axillary artery here. This is the coracoid process. There is a tumor in the coracoid process. This tumor compresses this part of the axillary artery. Assume that this part of the axillary artery is compressed by a tumor here. That part is the second part of axillary artery. So the middle of the axillary artery is compressed by a tumor. This is the third part of axillary artery. If this part of the axillary artery is blocked, blood can reach the third part of axillary artery through these vessels, taking a bypass route. Whenever the main road is blocked, we take the bypass road to reach our destination. Similarly, the blood does the same thing. Blood from the branches of the first part of the subclavian artery reaches the third part of axillary artery through its branches. Our exercise is to know the branches which take part in this anastomosis. This is one artery. It is a branch of the first part of the subclavian. Since it runs above the scapula, it is called suprascapular artery. This artery anastomoses with this artery, which is a branch of third part of axillary. This artery runs below the scapula, therefore called subscapular artery. And this is the site of anastomosis. You can see blood then can flow like this and can reach the third part of axillary artery. And this particular branch of subscapular artery winds around the scapula, therefore called circumflex scapular artery. Then there is one more site where the two branches anastomose. You can see this artery. This artery runs on the dorsal aspect of the scapula, a branch of first part of the subclavian. Dorsal scapular artery or deep branch of transverse cervical. This artery anastomoses with the continuation of the subscapular artery, also known as thoracodorsal artery, and this is the site of anastomosis near the inferior angle of the scapula. Because of these two anastomoses, blood reaches the third part of axillary artery. So, this anastomosis links the first part of subclavian artery with the third part of axillary artery. That is the reason why even if the rest of the axillary artery is compressed, totally blocked, blood can reach the third part of axillary artery through the subscapular artery. So these arteries are all very much dilated in such situation. Whenever the axillary artery is blocked, these arteries on the back of the scapula are very much dilated to provide collateral circulation. So the origin of subscapular artery, the site of origin of subscapular artery is very critical. Any occlusion of axillary artery above the origin of subscapular artery will not affect the blood supply to the upper limb. That is the inference. Conclusion. So if occlusion to the axillary artery occurs above the origin of subscapular artery, blood supply to the upper limb will not be cut off. On the other hand, if an occlusion or compression develops below the origin of subscapular artery, blood supply to the upper limb will be almost cut off. You have to amputate the upper limb. So which is a critical site? The site of origin of subscapular artery. Above the origin, occlusion of the artery is safe. Nothing will happen. But below this level, blood supply will be cut off. Amputation is required. So to eliminate the distractors, first of all you should know what they are, where do they come from in the question to eliminate the distractors. The axillary artery divided into three parts by the pectoralis minor muscle. The first part gives one branch, second part gives two branches, third part gives three branches. Which is the only one branch of the first part? This is the uppermost artery in the thorax. That is why it is called so. Supreme thoracic artery or superior thoracic artery. Two branches are given off by the second part of the axillary artery. Which are the two branches? Thoracoacromial and lateral thoracic. Thoracoacromial is also called acromiothoracic. Both are one and the same. Which are the three branches of the third part? You can see those three branches. This is the subscapular artery, one branch, and you can see two branches, two arteries encircling the surgical neck of humerus. This is the site where the surgical neck of humerus is formed, and two arteries encircle, therefore they are called circumflex humeral arteries, anterior and posterior circumflex humeral arteries. So three branches arise from the third part. One is subscapular, the other two are the anterior and posterior circumflex humeral arteries. So these are the branches of axillary artery. Now we are in a position to eliminate the distractors and to find out the right response for this question. If you choose anterior and posterior circumflex humeral, now you will laugh because they are the branches of third part of axillary artery. They are not going to help. Subscapular and brachial artery will not serve the purpose. Subscapular and posterior circumflex humeral, both are the branches of, again, third part of axillary artery, no use. Thoracoacromial and supreme thoracic arteries, they are the branches of first part and second part, so that also is not useful. So this is the only one that is more useful. Subscapular and suprascapular. You can remove this pair and put another pair in that place because we have seen two sides of anastomosis. Yes, dorsal scapular artery and thoracodorsal artery. Okay. Or even if the subscapular artery is given, you can choose because thoracodorsal artery is simply a continuation of the subscapular artery after giving up this circumflex scapula. So this type of question has been asked previously in your entrance examination. Moreover, clinically useful. So compression, occlusion of the axillary artery above the origin of subscapular artery will not affect the blood supply to the upper limb. That is the inference. When a person falls on outstretched hand, what all bones in our body are likely to be fractured? A person falls on outstretched hand. Let us start from the shoulder. Clavicle can be fractured at the junction between its two curvatures. Two curvatures means medial 2/3 and lateral 1/3. Clavicle can be fractured when a person falls on outstretched hand. Any part of the humerus? Supracondylar fracture. Radius can be fractured where lower end of the radius. What is that fracture called? Colles fracture. And a carpal bone also is likely to be fractured. Here the physician is able to elicit tenderness between the tendons of two muscles. What is that site called? That site is known as anatomical snuff box. It is a shallow depression between these two tendons. Abductor pollicis is longest and extensor pollicis is longest. Two carpal bones form the floor of the anatomical snuff box. Anyway, which one you want to choose for this question? Show your digits. Number 2. Okay, scaphoid, let us see. This is the muscle extensor pollicis longest because it extends the thumb. And this one is called abductor pollice is longest because it abducts the thumb. And this shallow depression between these two is the anatomical snuff box. 4 bones are related to the floor of the anatomical snuff box. Which are the 4 bones? We will see. Yes. This bone is the lateralmost bone of the proximal carpal bones, proximal row. Lateralmost carpal bone of proximal row. What is that? Which are, do you remember the names of all 8 carpal bones from lateral to the medial side? Proximal row. First, let us start from the thumb side. Scaphoid, lunate, trichotrum, pisiform. Similarly, from the distal row, trapezium, trapezoid, capitate, hamate. Okay. So these are the 8 carpal bones. So you are seeing the lateralmost bone of the proximal row. So which one it is? Scaphoid. Similarly, the lateralmost bone of the distal row, trapezium. These are the 2 carpal bones forming the floor of the anatomical snuff box. In addition, we see 2 more, the styloid process of the radius and the base of first metacarpal. Any of these bones can be fractured, but the one which is commonly fractured is the scaphoid. You can see the scaphoid fractured. Following fracture of the scaphoid, a swelling appears in the anatomical snuff box. Wherever bone is fractured, swelling. All signs of inflammation will be there. What is the other name given to the wrist joint? Is it called radiocarpo-ulnar joint? Only radiocarpal joint. Why ulna is not included? Because ulna does not take part in the formation of wrist joint. Radiocarpal joint only. You see there is a very large gap here between the ulna and the carpal bone. This gap in the living is filled by an articular disc, interarticular disc. Therefore, ulna does not take part in the formation of wrist joint. That is why the wrist joint is also called radiocarpal joint. Radiocarpal. Of the 4 bones of the proximal row, how many articulate with the radius? Only 3. 3 bones articulate with the radius. This is the scaphoid, this is the lunate, this is the trichotrum. Pisiform is the smallest of the carpal bones and it does not articulate with the radius. Only 3 carpal bones articulate: scaphoid, lunate and trichotrum. Pisiform does not articulate. It is the smallest of carpal bones. It differs from all other carpal bones in that it is a dash bone. Sesamoid bone, correct. Developing in the tendon of flexor carpi ulnaris. Sesamoid bone will develop in the tendons of muscles. The largest sesamoid bone that we see in our body is the patella, developing in the tendon of quadriceps femoris. Though this is the smallest bone, the last carpal bone to ossify is the pisiform. Pisiform is the last carpal bone to ossify. When does it ossify, do you know? 12th year. 11th year in females, 12th year in males. So, it is the smallest of carpal bones. It is a sesamoid bone developing in the tendon of flexor carpi ulnaris and the last bone to ossify. How will you confirm the fracture of scaphoid? You will take an X-ray of the wrist, AP view or lateral view. It is neither AP nor lateral because in the usual view, AP and lateral view, the fracture line is not clearly visible. If you take an X-ray in oblique view means this is also oblique, this is also oblique. This is called radial deviation, this is called ulnar deviation. In which deviation will you take an X-ray of the wrist? Look at this. Okay, this is the scaphoid and this is the lunate and this is the trichotrum. These 3 bones articulate with the radius. but the pisiform does not articulate. Now let us see the next one. If you take an X-ray in the routine AP view, the fracture line is not so conspicuous. But the same X-ray taken in ulnar deviation, you can see the fracture line very clear. The site of fracture is clear. That is why we must, otherwise we are likely to miss the diagnosis. If we take X-ray in the routine view, even if the scaphoid is fractured, we won't be able to see the fracture line, so we will miss the diagnosis. Therefore, X-ray must be taken in this view. What is the complication of scaphoid fracture? Avascular necrosis. Why? This diagram will tell you. Here is the scaphoid which is fractured. Usually scaphoid is fractured in the middle between the two expanded ends. This area of the scaphoid, this part of the scaphoid is called isthmus. So isthmus is the one that is commonly fractured. Now what happens following fracture of the scaphoid? The blood vessel supplying the scaphoid is now confined to the distal fragment only, lower fragment only. The proximal fragment is now deprived of its blood supply. There is no blood vessel now for the proximal fragment. Therefore, it undergoes avascular necrosis. Right. So what you have chosen is perfectly correct. Scaphoid is the right answer for this question. So point tenderness can be elicited in the region of the anatomical snuff box following fracture of scaphoid. Three structures cross the anatomical snuff box. Which one you want to eliminate from the list? Number 4. Okay, we will see. One artery, one vein and one nerve. Easy to remember. The vein is the cephalic vein. It's a very long vein starting from the dorsum of the hand, goes up to the pectoral region, pierces the clavicular fascia and ends in a large vein. And this nerve is the superficial branch of radial nerve. And this artery, which artery? Radial artery. So radial artery leaves the anterior compartment of forearm he reaches the dorsum of the hand by crossing the anatomical snuff box. So artery, now these three things anatomical snuff box, but the tendon of extensor pollicis is longer, forms only a boundary, not a content. It is not a content, but a boundary of anatomical snuff box. What is the significance of knowing the superficial branch of radial nerve in this area? You know the disease in which all peripheral nerves are very much thickened? Leprosy, Hansen's disease. Superficial nerves which are placed superficially in our body can be examined for thickening to confirm the diagnosis of Hansen's disease. Which are the nerves that are usually examined for thickening in our body for confirming diagnosis? Two nerves are there in the upper limb. One is the ulnar nerve behind the medial epicondyle. The other nerve in the upper limb is the superficial branch of radial nerve. How will you feel this radial nerve here? Even in all normal individuals, this nerve is palpable. Just like we palpate the ulnar nerve, this nerve also can be easily palpated. How? Even now you can try, you can find out whether the nerve is palpable or not. You can confirm. All you have to do is just extend your thumb to make the tendon of extensor pollicis longus prominent. Extend your thumb like this. Thumbs up, that position. Now the tendon has become very prominent. Keep the index finger of your other hand over the tendon of extensor pollicis longus. Where the tendon begins from the wrist, keep the index finger of your other hand over the tendon. Now just roll over the tendon. You just make up and down movement in the direction of the tendon. Do you feel anything over there? Something is touched by your finger. This is the superficial branch of radial nerve. It is invariably felt in all individuals. In leprosy, this nerve is very much thickened. It is easily palpable here. Yes, you have to make this rolling movement in the direction of the tendon, not across the tendon, in the direction of the tendon, parallel to the tendon. Then only you will be able to feel the nerve. Which are the nerves that are palpable in the lower limb? One nerve is there, common peroneal nerve, where it winds around the neck of the fibula. The nerve is very superficial. It winds around the neck of the fibula. Any nerves in the head and neck area? There is a nerve crossing the angle of the mandible, great auricular nerve. Great auricular nerve runs superficially. This nerve is very much thickened. In a well-established case of leprosy, you need not even palpate the great auricular nerve. It is simply visible. It is enlarged to such an extent that it becomes visible. You can see a tortuous course of that nerve crossing the angle of the mandible here. Then two more nerves are there in the forehead. They are the supratrochlear and supraorbital nerves. Supratrochlear, supraorbital. These are nerves which can be palpated in Hansen's disease. Supraclavicular nerves running on the shoulder, over the shoulder, anterior to the shoulder, they also can be palpated in Hansen's disease. Supraclavicular nerves. So these are the nerves which are placed superficially in our body, and therefore they can be tested for thickening in Hansen's disease. Want to take down that supraclavicular nerve, supraclavicular, supratrochlear and supraorbital, great auricular. Four nerves are there. One nerve in the lower limb, two nerves in the upper limb. Okay, so this is not the right answer for this question. Why this light? Okay. So single switch for both, I think. This question has been asked previously in your All India Entrance Examination. This question describes all about the radial nerve. Which of this is true if the radial nerve is injured near the lower part of radial groove? We know three nerves are intimately related to the humerus. Which are the three nerves which are intimately related to the humerus? Axillary nerve winding round the dash of the humerus, cervical neck of humerus, radial nerve to the shaft of the humerus, that is in the radial groove, and ulnar nerve behind the medial epicondyle. So if these parts of the humerus are fractured, these nerves are in danger of being damaged. Axillary nerve, radial nerve and ulnar. Here the radial nerve is injured in the lower part of spiral groove. The other name given to the radial groove is spiral groove. Which of these could be true? Number 2. Then what? Results in paralysis of unconeus muscle, because unconeus muscle is in the elbow. So naturally if the nerve is damaged above the elbow, muscle is likely to be damaged. So logic wise perfect. Pardon? Anything else? Number 4. Weakens the pronation movement. Alright. We will find out whether it can produce weakness of pronation or not. Then what else? Number 3, leaves extension at the elbow intact. Then only one thing remains now. We can eliminate one distractor even before seeing any diagram. See, pronation, supination. These are the two movements occurring at the radioulnar joint of the forearm. Pronation is carried out by two muscles. These muscles are known by their action. What are they called? Pronator teres and pronator quadratus. These are the two muscles, pronator teres and quadratus. Are they supplied by the radial nerve? No. They are supplied by median nerve. So you can eliminate that distractor immediately. It will not affect the pronation because these muscles which are responsible for pronation are supplied by median nerve. Now only 3 choices are left. 1, 2, 3. We will see the diagram. We have exposed the radial nerve on the back of the arm, posterior compartment of arm. Here we see 3 heads of the triceps. All 3 heads of the triceps are supplied by the radial nerve. And this is the muscle responsible for extension of the elbow. So, if the radial nerve is injured, triceps will be paralyzed. Extension of elbow will not occur. That's what we usually think. But before that, we shall see the course of the nerve. Here is the nerve in the radial groove, posteriorly. This head of the triceps is the long head. Long head is here. This is the lateral head. You have to cut and divide the lateral head to expose the radial nerve in the radial groove on the posterior compartment of arm. This is the medial head of triceps. These are the 3 heads of the triceps. Now you see here, the nerve is going to be damaged somewhere here. This is the site where the nerve is going to be damaged. You can see the radial nerve giving branches to the long head of the triceps even before reaching the radial groove. When the nerve is in the axilla, the nerve gives branches to the long head. Therefore, will it be paralyzed if the radial nerve is damaged in the lower part of the radial groove? No. Then the nerve gives off branches to the lateral head throughout the course, even before reaching the lower part of the radial groove. Also giving branches to the medial head. You can see a long branch is given off by the radial nerve just very close to the upper part of the radial groove. When it is in the upper part of the radial groove, it gives a long branch. This branch supplies the medial head. You can see the branches to the medial head. It goes down, further down, down here to supply this muscle, unconeus. So unconeus is supplied by a branch that arises from the radial nerve well above the radial groove. So do you expect paralysis of unconeus following injury to the radial nerve in the lower part of radial groove? No, because this branch is given off by the nerve well above. So all 3 heads of the triceps are not going to be paralyzed by the paralyzed due to injury to the radial nerve in the lower part of radial groove. And these are the 3 heads responsible for extension of the elbow. Will the extension of the elbow be intact or not? If the radial nerve is injured in the lower part of radial groove, it will not affect the extension of the elbow because the muscles are not going to be paralyzed if the nerve is injured in the lower part. Unconeus also is not going to be paralyzed because that branch comes from the upper part of the radial nerve. Pronation will not be affected because it has nothing to do with the pronation of forearm. The nerve, after passing through the radial groove, pierces the lateral intramuscular septum and enters the cubital fossa. There are two muscles coming from the lower part of the humerus. This is the extensor carpi radialis longus and this is the extensor carpi radialis brevis. After leaving the radial groove, the nerve supplies these two muscles in the lower part of humerus. Extensor carpi radialis longus and brevis are supplied by the radial nerve after leaving the radial groove. Once it pierces the intramuscular septum, it supplies these two muscles and leaves the intramuscular septum to reach the cubital fossa. So radial nerve is a content of cubital fossa. What about ulnar nerve? Ulnar nerve is not a content of cubital fossa because you see the ulnar nerve here, it runs behind the medial epicondyle and enters the anterior compartment of forearm distal to the cubital fossa. Therefore, it is not a content, but the nerve which was there in the posterior compartment of arm is going to become a content of the cubital fossa because it pierces the lateral intramuscular septum and reaches the cubital fossa, that is radial nerve. So, nerve supply to the extensor carpi radialis longus cannot be spared. Why? They will be paralyzed. The extensor carpi radialis longus and brevis will be paralyzed. So that statement is not correct. Results in paralysis of unconeus also is not correct. Weakens pronation also not correct. Then what is correct? Yes, leaves the extension at the elbow intact. Triceps not paralyzed in spite of injury to the radial nerve. All three rest of the triceps are supplied by the radial nerve, but none of them is paralyzed following injury to the radial nerve in the lower part of radial groove. Even if the radial nerve is injured in the middle of the radial groove, one head of the triceps will not be affected. Which is that head? Long head will not be affected because the nerve gives off the branch even before reaching the radial groove. Only those who know all about the radial nerve can answer this question correctly. Otherwise, it is a complicated question. Everything is there about the radial nerve in this question. There is a triangular area on the back, medial to the scapula. We usually keep the stethoscope always medial to the scapula, in the interscapular space. So, medial border of the scapula is definitely a boundary of this triangle, should be a boundary of this triangle. Which are the other two muscles forming the boundary and which one you want to eliminate from the list? You have already eliminated one, medial border of the scapula, because medial border of the scapula will definitely be there. Because we keep the diaphragm of our stethoscope medial to the scapula to hear the breath sounds. In this part of on the back, breath sounds are heard much better than in any other area on the back. That is why this triangle is known as triangle of auscultation. Which one you want to eliminate from? We have already eliminated one, only three things are there. After three, which one you want to eliminate? Number 2. Okay, then what else? Pardon? Look at this triangle. This is the triangle of auscultation. It is a gap between two large sheet of muscles. Two large muscles, a gap between these two. Which are they? Trapezius above, latissimus dorsi below. Both are two large sheet of muscles on the back. A gap is there between the two, bounded laterally by the medial border of scapula. Rhomboides minor muscle is seen here. Major is of course seen within the triangle, but it does not form a boundary. It forms the floor of the triangle. Rhomboid is major, but minor is above, it is under cover of trapezius. So this muscle has no role to play in the formation of this triangle. This triangle is actually formed by two large muscles, trapezius above, latissimus dorsi below, limited laterally by the medial border of scapula. Rhomboid is minor. There is a question about, yes. We must know something more about that muscle. Latissimus dorsi. In case of injury to thoracodorsal nerve, which of the following may be difficult to carry out? Lifting a heavy object from the ground, climbing a tree, carrying a heavy object on the shoulder, pushing a heavy door to open. Which of these? Thoracodorsal, first of all, you should know the muscle supplied by the thoracodorsal nerve. After that only you are fit to read the question. Otherwise, it's difficult to answer. Which muscle is supplied by thoracodorsal nerve? Latissimus dorsi. Correct. We have seen this muscle, latissimus dorsi, here in the previous diagram. You are seeing this muscle here. It's a very large muscle taking origin from the thoracolumbar fascia and giving partial insertion to the inferior angle of the scapula. Then it's moving like this, forming the posterior axillary fold. When we keep our arms like this, posterior axillary fold is formed, and that fold is contributed by the latissimus dorsi. It goes to be inserted into the humerus along with two more muscles, which are the other two muscles having the same size of insertion as that of latissimus dorsi. Pectoralis major and teres major. So there is a tip used for this. A lady between two majors. Lady is the latissimus dorsi. The two majors are the pectoralis major and teres major. These three muscles are inserted into the bicipital groove or intertubercular sulcus of the humerus. We will see the intertubercular sulcus later. So three muscles are attached to a common site in the humerus, and therefore they will have a common action. What common action? Suppose we have kept our arms like this. When these three muscles, pectoralis major from the anterior side, latissimus dorsi from the posterior side, including the teres major, these three muscles contract, what will happen? What is this movement? Adduction. So they are powerful adductors of arm at the shoulder. Powerful adductors. And also, the intertubercular sulcus is placed medially on the humerus. Therefore, when these three muscles contract, the humerus is rotated medially, internally rotated. So these three muscles have common action because of the virtue of their site of insertion, adduction and medial rotation. In which way they differ in their action? Any action other than this. Pectoralis major is in front of the body, therefore it can produce flexion. The other two muscles are on the back of our trunk, therefore they can produce extension. That is the way they differ. Of the same muscles, pectoralis is for moving the arm forward, the other two muscles are responsible for moving the arm backward, extension. Otherwise, they have a common action as far as adduction and medial rotation are concerned. Now we will see the question again. Lifting a heavy object from the ground. A heavy object from the ground. Possible using this muscle. Carrying a heavy object on the shoulder. Which muscle is responsible for this? Trapezius, but what is this prominent muscle forming the bulk of the shoulder? Deltoid is required. So lifting the heavy object from the ground, there are several muscles acting to lift. Mainly the extensor of the vertebral column, the erector spinae, straightening the vertebral column while lifting the heavy object from the ground. So that you can eliminate. Carrying a heavy object on the shoulder is because of the contraction of deltoid here. That also you can eliminate. Pushing a heavy door to open. Which muscle is responsible for this? Serratus anterior. So serratus anterior is required for pushing anything from the front. Now climbing a tree is the one that is left. We want to climb a tree. Okay, we have fixed our hands on the stem of the tree above our head. Above our head, we have fixed our hands on the stem of the tree. What is the next step to climb the tree? Elevating the trunk. Now the trunk is elevated after fixing the hands on the tree. What is actually happening now? Adduction occurs. Yes, adduction means you can bring the arm to the side of the trunk, and if the arm is fixed, you can take the trunk to the side of the limb. In this case, the hands are fixed, upper limb is not moving, we are lifting the trunk to produce direction. For this purpose, our latissimus dorsi is required. That is why latissimus dorsi is also known as climber's muscle. When a person climbs the tree, you can see, if he does not wear any dress, you can see this muscle becoming very prominent on the back. Flattened, triangular shape. The triangular shape of the body can be easily appreciated at that time. This muscle undergoes contraction. Not only this muscle, the pectoralis major and teres major. These three muscles undergo contraction. Of the three, the most powerful adductor of the humerus arm is the latissimus dorsi. So, which is going to be the right answer for this question? Exactly, climbing a tree. So, boxer's muscle, serratus anterior. Climber's muscle, runner's muscle, gluteus maximus. Walking muscles, gluteus medius and minimus. So these are the other terms used for. Remember, for walking purpose we need gluteus medius and minimus, and for running, gluteus maximus. You come across a case of wrist slash of committing suicide. Some tendons have been cut. There is profuse bleeding. You are seeing the wound. You want to identify these tendons and you want to suture the tendons and close the wound. So some anatomy is required before doing this. You want to do reconstructive surgery of hand in a case of Hansen's disease. Reconstructive surgery. Other tendons can be, anastomosed, linked for moving the digits in such situation. Or we can take one muscle itself and transplant it in some other area for moving that part. So which of these first to locate the median now in the wrist? I am going to ask you one more question in this regard. A person tries to commit suicide by slashing the wrist. Which of these structures is least likely to be damaged? I am going to give you the choices. I am going to give you the 4 choices. Of the 4, which is least likely to be damaged while attempting suicide by cutting the wrist? Radial artery, flexor carpi radialis, median nerve, palmar is longest. കുഴപ്പമില്ല കേട്ടോ, അത് ഞാൻ ഇങ്ങനെ കൈ വെച്ചതുകൊണ്ട് ശ്രദ്ധമാനതാണ്. സൗണ്ട് എത്ര വേണം. Of the four, which is least likely to be damaged? Median nerve. Why do you want to choose median nerve? Median nerve is not so superficially placed. It is placed deep to a tendon. That tendon serves as a guide to locate the median nerve. Which is that tendon? Palmar is longest. Okay, we will see. This is the median nerve, and the tendon that runs along with it is the palmar is longest. Whether the person is right-handed or left-handed, usually while doing suicide by cutting the wrist, they actually start from the radial side of the wrist. By the time the cut reaches the ulnar side, it becomes superficial. Therefore, ulnar vessels and nerves are not usually damaged, because when we start the cut from the lateral side, from the thumb side, by the time the cut reaches the ulnar side, it becomes superficial. Unless the person is very much determined, okay, I must die. Applying equal pressure till the end. So the median nerve runs in close relation with the palmaris longest tendon. The tendon and the nerve may have the same caliber. One may be mistaken for the other. Median nerve may be mistaken for the tendon. Tendon may be mistaken for the median nerve. You want to suture the tendon following injury. Sometimes, you will take the median nerve and suture it with the other part of the tendon. That should not occur. So for that purpose, we must know the relation of all these things. Similarly, the radial artery, that should be cut, otherwise suicide will not be successful. Radial artery runs in close relation with the tendon. Which is that tendon? We feel the radial artery, radial pulse between two tendons. They end with the term radialis. This is flexor carpi radialis, and which radialis it is? Brachioradialis. So we feel the radial pulse between two radialis tendons, flexor carpi radialis and brachioradialis. So flexor carpi radialis serves as a useful guide to locate the radial artery. Similarly, ulnar nerve also runs in relation to a tendon, which is that tendon, and this tendon is attached to this bone, which is the smallest of carpal bone. Actually, this bone develops in this tendon. I have given you necessary clue to identify this tendon. Flexor carpi ulnaris. In which way all these things are related to their respective tendons? The neurovascular structures run lateral to their respective tendons. Underline the term lateral. That is the relation they keep with their respective tendons. You see that? Radial artery lateral to the flexor carpi radialis. Median nerve lateral to the palmaris longest. Ulnar nerve lateral to the flexor carpi ulnaris. They maintain a lateral relation to the tendon. So medial one will be the tendon, lateral one will be the nerve or the artery. That is how these things are identified in the wrist. The median nerve not only runs lateral to the palmaris longest tendon but also deep to it. That is why it is not usually damaged in a case of wrist lash unless the cut is so deep. A cut injury deep, exactly in the middle of the wrist, can damage the radial nerve. One of the sites of injury to the radial nerve is near the wrist. The nerve is a little bit superficial. You can see the nerve here. So what you have chosen is perfectly correct. The cervicoaxillary canal is a triangular gap. It is through this triangular gap all neurovascular structures from the neck descend into the axilla. We see the brachial plexus, subclavian artery becoming the axillary artery, all those things happening while passing through this canal. It is a triangular gap bounded by three structures. This is what is called apex of the axilla. Nerves and blood vessels from the neck enter the free axilla through this gap. Which one you want to eliminate from the list? Pardon? Get off? Humerus. Okay. You will see. The arrow in this picture has passed through the cervicoaxillary canal. Which bone is there in front? Yes. Which bone is there behind? Scapula. Which bone is there along the medial aspect, that is along the side of the neck? That is first rib. So, anteriorly we see the clavicle, posteriorly we see the scapula, upper part of scapula, and medially limited by the first rib. This triangular transmits all neurovascular structures from the neck to enter the free upper limb. The head of the humerus does not keep any relation with this canal. It is farther away. Head of the humerus, if at all present, it will be seen somewhere here. Has no relation to this gap. So what you have chosen is perfectly correct. Head of the humerus. Yes, expect less than other. You will be contented. We expect more than others, dissatisfaction, disappointment, frustration, all those things will come. This cricket player finds it difficult to feels pain during pitching motion. It is a case of painful abduction. There is a syndrome called painful arc syndrome. Whenever abduction is attempted, pain is felt. The person avoids taking abduction because of pain. Due to two reasons, which I will tell you later. Find out the right response for this question. Which one you want to choose? Number 4. Number 4 means supraspinatus muscle. Number 1, coracoacromial ligament injury. Alright. Cricket players, especially the bowlers, often have this problem. What injury? This time, shoulder injury. But which structure is more prone to injury in such person? Okay, we will see. This is the situation. What structure is this? What is this group of muscles called? Yes, a case of rotator cuff injury. Rotator cuff injury is quite common in baseball players, cricket players. Rotator cuff injury. How many muscles surround the shoulder joint to form the rotator cuff. Which are they? They are collectively called sits muscles. S-I-T-S, sits muscles. We have supraspinatus, I for infraspinatus, T for teres minor, one more S, the last S, subscapularis. So these are the cells forming the rotator cuff. Therefore, the one which is commonly injured is which one? Supraspinatus injury is quite common in. What is the action of the supraspinatus? We have already studied. Initiation of. If the tendon is initiation of abduction is lost due to inflammation in the beginning, pain is felt. Whenever the person tries to abduct the arm at the shoulder, pain is felt due to injury to the tendon of supraspinatus, as you see in this picture. The other condition which can produce painful abduction is, you are seeing a bursa here. What is the bursa? What is this bursa called? Subacromial bursa. We will see the bursa in this picture. You can see this synovial bursa. This is the synovial bursa in our body. This is that bursa. Subacromial bursa is the largest synovial bursa body. Why is this bursa called subacromial? What is this structure? Acromion. So it lies below the acromion, therefore called subacromial bursa. Also lies below the deltoid muscle. See, deep to the deltoid muscle also, this is one, therefore it also is called subdeltoid. It has two parts, subacromial part and subdeltoid part. This is the large bursa. Suppose this is inflamed. It's filled with fluid, extended with fluid. It is very much enlarged when it is inflamed. You are seeing something above the bursa. What is this structure called? The three things together. What is this arch called? Coracoacromial arch. How many structures form this arch? Coracoid process, anteriorly, coracoacromial ligament, and the acromion. These three things form an arch. This arch forms a secondary, provides a secondary socket for the shoulder joint. Now the bursa is distended with fluid and inflamed. The person tries to abduct the arm like this. What will happen? The distended bursa will be compressed by the coracoacromial arch. That produces pain. This is what is called painful arch syndrome. So there are conditions which can produce pain. One is injury to the tendon of supraspinatus. Number two, painful abduction. You must suspect injury to these two conditions. Injury to the tendon with the history of trauma and inflammation of this bursa. Subacromial bursitis. Okay, a person is having injury to the tendon of supraspinatus and therefore he is not able to initiate abduction. How the person tries to overcome this difficulty for moving the arm, for producing abduction? Well, with the help of the other hand, he can push the affected hand a little bit away from the side of the trunk to overcome the initial difficulty with abduction. This is one way. But after some time, the person will learn a method by which it could be overcome. What is that? Yes, see, See, when we stand erect like this, our arm, our upper limb is by the side of the body. When we bend our vertebral column sidewise, what happens? Because of gravity, the limb is always vertical. But now, what has happened is now that 15-degree abduction has already occurred. A 15 to 35-degree abduction occurs when we simply bend the vertebral column laterally. So what the persons do overcome this difficulty by simply bending the vertebral column. Afterwards they can do the abduction up to 90 degree because this is carried out by which muscle? Delta. Therefore, abduction will not be affected, but the initiation of abduction will be affected due to injury. So the right answer for our question is injury to the supraspinatus. You are seeing something in this picture coming out from the shoulder joint. What is this thing? Long head. You see, the origin is quite peculiar. This muscle is within a joint from the supraglenoid tubercle. It starts from the scapula, supraglenoid tubercle, but the tendon passes through the joint and even tubercle is within the shoulder joint, within the capsule, covered by the capsule of the shoulder. So what type of origin does this muscle have? Intracapsular origin. A muscle origin within a joint. This is the only muscle in our capsular origin. There is that is popular. These two muscles differ from other muscles in our body in that they are joint. They are origin. And this is what is the name given to this sulcus? That is intertubercular sulcus, because you see the greater tubercle here, lesser tubercle here. Since the sulcus lies between the two tubercles, it is called intertubercular sulcus. It is other name given to the intertubercular bicipital groove. You know why? Because the long head of the biceps passes through this groove. This groove transmits the long head of the biceps, therefore called tendon of long head of biceps. Supraspinatus muscle, inflammation of the so in a case of fracture of the clavicle, the arm is lost. Even before taking X-ray, you can diagnose clavicular fracture, because when the person walks, the forward and backward movement of arm, when we walk like this swinging movement, this will be lost. You know why this happens? Why the swinging movement is absent in a case of fracture of clavicle? Because this is the bone transmitting the weight of the upper limb to the axial skeleton. Because this is the only long bone in our body placed horizontally, connecting the appendicular skeleton with the axial skeleton. So weight of the upper limb must be properly transmitted to the axial skeleton. Only then this swinging movement is possible. If this weight transmission is interrupted, swinging movement cannot occur. So if the clavicle is fractured, this line of transmission is interrupted, weight of the upper limb is not transmitted, therefore swinging movement becomes absent. There is a ligament responsible for transmitting the weight of the upper limb to the axial skeleton, which is that ligament. This ligament starts from the coracoid process
is attached to the clavicle. You need more clue? Yes, corococlavicular ligament. Corococlavicular ligament is the one that transmits the weight of the upper limb to the axial skeleton. If you divide this ligament, no more transmission. Swinging movement will be lost. So this ligament transmits the weight of the upper limb to the axial skeleton. There are some vacant chairs. Some of them can come and sit. Why 2 chairs are kept vacant here? There also 1 or 2. This side 1 or 2. Some of you can, okay, after the tea break you can come and sit here, no problem. Well, here the greater tubercle is fractured and displaced from the rest of the humerus. Therefore, the muscles attached to the greater tubercle are not able to function now. Thus, the greater tubercle itself is displaced from the humerus following fracture. The muscles attached to it are not acting now. If so, which of these movements are likely to be affected if the greater tubercle is displaced? That is the question. First of all, to answer this question, you should know the muscles attached to the greater tubercle, then their action. Which one you want to choose before going to see the diagrams? Number 1. Then what? Any idea? The person having fracture of the greater tubercle will have this difficulty. What made you choose number 1, greater abduction and lateral rotation? Or inaction of which muscles do you suspect in this case? Inaction. Supraspinatus, infraspinatus and teres minor. Okay. Alright, we will see. When the greater tubercle is fractured and displaced from the humerus, the 3 muscles attached to the greater tubercle are not able to function. Which are they? You see here in this picture, the 3 digits are kept over the greater tubercle. The thumb is placed over the lesser tubercle. The 3 digits represent the 3 muscles attached to it. They are supraspinatus, infraspinatus and teres minor. They are also called sit muscles, SIT muscles, sit muscles. These muscles sit on the greater tubercle. Which muscle is attached to the lesser tubercle? Subscapularis. What is the common term used for these 4 muscles? Muscles of rotator cuff, musculotendinous cuff of the shoulder. Which part of the shoulder joint is weak, is more prone to dislocation? Inferior part. Inferior dislocation of the humerus is common. You know why? This diagram will tell you. Suppose a person gives a gentle tap from above, the humerus will fall down because there is nothing to support the humerus from below. The muscles of the rotatory cuff surround the shoulder joint, surround the head of the humerus everywhere except below. So that is why inferior dislocation, also known as anterior dislocation clinically, both are one and the same, occurs frequently. Upper part of the humerus is supported by the muscles of the rotator cuff and coracoacromial arch, which forms a secondary socket for the joint. Therefore, upward dislocation, displacement of humerus does not occur, cannot occur. But downward displacement of head of humerus can easily occur because these muscles do not support the humerus from below. Now let us see the action of these muscles. This muscle is called supraspinatus because it arises from the supraspinous fossa. This is the spine of the scapula. Above this muscle, above this process, that area is called supraspinous fossa. So this muscle taking origin from there is called supraspinatus. Where does it go? It goes to this greater tubercle. Which muscle is this? Infraspinatus, a very large muscle occupying the dorsal aspect of the scapula below the spine. This muscle also goes to the greater tubercle. And this one, teres minor, all three are attached to the greater tubercle. Now you can see the ventral surface of the scapula. The ventral surface is totally covered by a flat muscle, and that muscle is inserted into the lesser tubercle. Which muscle is this? Subscapularis. Action of any muscle in our body must be understood based on the direction of the fibers of that muscle. We use two terms for the attachment of muscle to a bone. One we call origin, the other we call insertion. On what basis? Both are attachments of the muscle to the bone. One attachment we call it origin. The other attachment we call insertion. On what basis? When a muscle contracts, the part that gives origin to the muscle usually does not move. It remains stationary. The part that gives insertion to the muscle moves. That is how the two terms are used. Origin site usually remains stationary. The other site called insertion because that site moves. The bone giving attachment to that muscle moves when the muscle contracts. That is how we use these two terms. Now these three muscles take origin from the scapula and are inserted into the humerus. So it is the humerus that moves when these three muscles contract. We have already seen the action of the supraspinatus. What is it? The fibers always, pull the bone towards their site of origin. All muscle fibers, when they contract, they will pull the bone from the site of their insertion to the site of their origin. That is the principle. If you know the orientation of fibers of any skeletal muscle in our body, you need not strain your memory to understand the action of muscle. Action of muscle should not be mugged up. It should be understood based on the direction of the fibers. You can find out the answer easily if you know the orientation of the muscle fibers in our body. We can say what action could that muscle carry if the muscle contracts. That is how it should be studied rather than mugging up all the origin, insertion, supply, etc. action. So this muscle pulls the greater tubercle towards the origin. So what will happen to the humerus? It will be lifted a little bit. Initiation of abduction will occur. And these two muscles, that is the action of the supraspinatus. These two muscles pull the greater tubercle towards their origin obliquely. So what will happen? Lateral rotation will occur. The humerus will rotate outwards laterally. Now this muscle, subscapularis, is attached to the lesser tubercle. So it will pull the lesser tubercle, which is placed more medially in the humerus. What will happen? Humerus will rotate medially. Look, humerus will rotate medially. That is the reason why these muscles are also called muscles of rotator cuff. Not only musculotendinous cuff, also known as the rotator cuff. Why? Because they rotate the humerus both medially and laterally. And the only muscle among the rotator cuff group that does not rotate the humerus is supraspinatus. So the other muscles rotate the humerus medially and laterally. That is why they are called rotator cuff muscles. And the only one that does not rotate the humerus is the supraspinatus. So if the three muscles attached to the greater tubercle cannot act following displacement of greater tubercle, which actions will be lost? Answer. Very simple now. abduction and lateral rotation will be affected. About the nerve supply of these muscles. These are the nerves innervating the four muscles of the rotator cuff. Which one you want to eliminate from the list? Such a difficult thing to find out the right response for this question. Number 3. See, we have studied these nerves already. We have seen the suprascapular, we have seen subscapular, subscapular artery we have seen, more than nerve we will see. Thoracodorsal axillary we have discussed. Axillary you want to choose. Okay, because you think that the axillary nerve supplies the deltoid muscle, so deltoid is not a muscle of the rotator cuff, so axillary is okay. Then thoracodorsal you want to choose. Okay, thoracodorsal now supplies the which muscle? Latissimus dorsi, which is not a muscle of the rotator cuff, therefore correct. Then what? So there are two now. Axillary now supplying the deltoid. Deltoid is not a muscle of rotator cuff. Thoracodorsal now supplies the latissimus dorsi, which is also not a muscle of rotator cuff. So there are two things to be eliminated now. Now what about the other two, suprascapular and subscapular? Which muscle is supplied by the suprascapular nerve? Supraspinatus. Supra and both supra and infra. Alright, right. What about subscapular? Subscapular. So are they the muscles of rotator cuff or not? Yes. No, axillary is there and thoracodorsal. Yes, you see, that is why I told you in the beginning. You all think that the axillary nerve supplies only one muscle, that is meant for the axillary, this deltoid muscle only. No, it supplies one more muscle. I will show you that nerve, that branch going to the deltoid along with the subsequent questions. Two muscles are supplied by the axillary nerve. Major muscle is deltoid and the small muscle is teres minor. Teres minor also is supplied by axillary nerve, remember. Two muscles. These two by suprascapular. Subscapular is below the scapula and nerve also should be named accordingly. Subscapular nerve. So thoracodorsal nerve supplies the latissimus dorsi, which is not a muscle of rotator cuff. Simple questions, but chance for making mistake there. This is a case of cervical rib. It is given in the question itself. You must say in your memory to understand the question. This is a case of cervical rib. Cervical rib can produce neurovascular symptoms. It can damage a part of the brachial plexus, and you should know why the radial pulse becomes weak when the cervical rib is, when in a case of cervical rib. Which part of the brachial plexus you want to choose for this question? First of all, you should be thoroughly the parts of the brachial plexus. How the brachial plexus is formed, what are the trunks, what are the divisions, what are the cords, and what are the branches. So a part of the brachial plexus is injured due to an extra rib in the root of the neck. This is an extra rib posteriorly articulating with the 7th cervical vertebra. So costal facets we see only in thoracic vertebrae because they provide articulation for ribs. But in this case we see a costal facet in the 7th cervical vertebra also. It's an extra rib in the neck. If such a rib, it may be symptomatic or asymptomatic. Only when we take routine X-ray of chest, sometimes this rib can be found. The person will not have any complaint. In such a situation, don't tell the patient that the person has an extra rib. Because if you say something, I have an extra rib, so anything can happen sometime, if at all now, if not now, later at least. Never tell, because don't trouble the trouble until the trouble troubles you. So which part of the brachial plexus is injured in this case? Number 3. Okay. Anything else? Number 4, posterior cord. Okay. You can eliminate 2 distractors from this question immediately if you know the basic of brachial plexus. We have divided the brachial plexus into supraclavicular part and infraclavicular part. That means part of the brachial plexus in the neck, supraclavicular. In the axilla, infraclavicular. Which parts of the brachial plexus do we see in the root of the neck? The roots of the brachial plexus and the trunks of the brachial plexus. The roots, the ventral rami of C5, C6, C7, C8 and T1 plus they form the trunks. Trunks and roots of the brachial plexus are found in the neck. What do we see in the axilla? The cords and the branches of the brachial plexus. So cervical rib is an extra rib found in the neck. Cords are found in the axilla. So which distractors you can immediately eliminate even before knowing? The 2 cords you can immediately eliminate. Medial lateral cord, posterior cord, all such cords are found below the clavicle. That means they are in the axilla, so they are unlikely to be damaged by an extra rib in the neck. Only trunks can be damaged. Which trunk and how? So we have eliminated 2 by simply knowing the position, relative position of the parts of the brachial plexus. Only 3 things remain. What's the 3? Which one you want to choose? More clinically related things, not simple anatomy only. 50% of orthopedics there, surgery is there. No idea. Okay, we will see the diagram now. Parts of the brachial plexus. How the brachial plexus formed? You see the ventral rami of all these 5 ventral rami, cervical and thoracic first. Can be easily understood if you take the 5 digits of your own hand. You just take the 5 digits of your hand, spread it like this. Then all you have to do is you just approximate the thumb with the index finger. Ring finger and the little finger approximate. Which finger is left alone? Middle finger. Okay, that is brachial plexus. Over. The thumb fuses with the index finger, that is the upper trunk. Ring and little finger fuse to form the lower trunk. The middle finger runs alone, that is the middle trunk. Over. Then what happens? Each trunk divides into an anterior division and posterior division. What happens to the posterior divisions of all 3 trunks from the picture? They all fuse to form which cord? Posterior cord. Only 3 anterior divisions remain. What you have to do is, you just fuse the upper 2 anterior divisions, leaving the lower one independent. The fused upper 2 forming what? Lateral cord. The lower one going singly, in single. That is the medial cord, over. So, we have trunks, divisions, cords, 3 branches. We will try to know the branches later. For the time being, let us see how the trunks and cords are formed. So, of the 5 parts, we see the roots and the trunks in the root of neck. The division is the place where a crossing is there, that is in relation to the clavicle, the divisions are found. Cross and branches are well within the axilla. Now you can see the inferior trunk continues as the medial cord. Medial cord gives off the ulnar nerve and all medially running nerves like medial pectoral, medial cutaneous nerve of arm, forearm, etc. Okay, we will see the situation. Here is the case of cervical rib. You are seeing the rib here, starting from here, ending here. This is the cervical rib. If posteriorly it articulates with the C7 vertebra, you can see that there is a costal facet here. Anteriorly it articulates with the first rib. If this rib may be complete, or it may be partly bony and partly fibrous band, or it may be completely a fibrous band. Different types of presentation are there with the cervical rib. What happens when a cervical rib is located in that area? You can see the three trunks of the brachial plexus on the first rib. One, first upper trunk, middle trunk, lower trunk. Which trunk is in contact with the cervical rib? Upper trunk, we call them based on their relation. Upper trunk will be above, middle trunk in the middle, lower trunk will be in the lower part. So which one is likely to come in contact with the cervical rib? Lower trunk. So what happens when there is an extra rib? This lower trunk is unduly stretched. It is pulled upwards, lower trunk, by the rib, and the fibers inside are broken. So it is due to undue stretching of the lower trunk of brachial plexus, this area undergoes undue stretching. So lower trunk means that trunk continues as what? Medial cord. Medial cord gives off the ulnar nerve, medial cutaneous nerve of arm, medial cutaneous nerve of forearm. They all innervate the medial aspect of our upper limb. Ulnar nerve innervating the medial 1.5 digits. The little finger and part of the ring finger. So pain will be felt or pain will be radiating along the medial aspect of the entire upper limb, radiating to the little and ring fingers because of damage to the lower trunk. Lower trunk continues as the medial cord. So all these things, pain will be radiated. How will you explain the feeble pulse in a case of cervical rib? This diagram will help you. Here is a complete cervical rib. This side it is partly bony and partly fibrous. Anteriorly it is fibrous tissue. Here it is bony. Such a thing can happen. Maybe unilateral or bilateral cervical rib. Now which muscles are there between the cervical rib in this case? Scalenus anterior is in front and scalenus medius is behind. Now our T-time. Right. You see here, this is the subclavian artery, and from the outer part of the first rib it becomes what? Axillary artery. Okay. So second part of subclavian artery is behind the scalenus anterior, and just behind that we see the cervical rib. This cervical rib compresses the second part of axillary artery. So that results in decreased blood flow through the upper limb. In order to compensate the decreased blood flow, normally whenever an artery is blocked anywhere in our body, to compensate the decreased blood flow, the part of the artery distal to the compression here usually undergo dilatation. This is what is called post-stenotic dilatation, so that it can accommodate more blood by dilating itself. This accounts for feeble pulse, feeble radial pulse. So which part of the brachial plexus is damaged in the case of cervical rib, and why pain is radiating on the medial aspect of the limb, radiating to the little and ring fingers? Now you know. So what is the right answer for our question? Which one? All of you, at least now you can show your digits, just for my satisfaction, whether you are actually following these things or not. So for that you don't have that energy to show your 3 digits. You can do it as a stretching exercise. You are simply sitting. Well, we have covered 13 questions. Tea is ready now. We shall have a short tea break and assemble after 5 minutes.